Right. I don't feel quite that ancient, actually. Yeah, but it is true. This retirement is killing me. I noticed that that Martin has posted the job now for the new head of the Clinical Scholars Program, and it looks good. I'm thinking of applying. So I couldn't see any reason why I wouldn't be eligible. So pays better than my present job. Anyhow, in any case, I loved yesterday's presentations. I mean, I thought that they were wonderful, and I thought it was a kind of a lovely lead-up to what I was going to say today. And so this is going to be about stories illustrated with data, I suppose. And I'm going to tell you a little bit about that. And I suppose it's true. I am kind of at the interface when family medicine was becoming a discipline. So I majored in political science. I was completely unprepared for this kind of work. I did bench research for a little while at Stanford, and it was a total failure. And the first 2 years of medical school were really rough for me because I had majored in political science, and I was surrounded by people who had PhDs, and they actually, brought me through. But I took a leave of absence from the medical school, and it lasted for a year and a half, and I wound up graduating with the following class. And during that period of time, I worked in Ethiopia, and it literally changed my life. I had been given much too much responsibility, and it meant that after I returned, I knew an awful lot more than some of the people who were teaching me, because that's what that kind of experience does for you. It also makes you kind of arrogant and difficult at times. I'll tell you more about that later, but just take note of the fact that I had attended more than 200 births before I had my obstetrical clerkship at Stanford. And we'll return to that story later. So this is a few pictures of the nurses at the Ethio-Swedish Pediatric Hospital in Addis Ababa, and the kind of work that I did in the field, which sometimes got a little bit scary, as you can see from this picture. And I had responsibility for a health center that I would visit out in the district, and I would bring home patients I couldn't care for back to Addis Ababa, and then return with them a couple of weeks later, hopefully improved. But I got very interested in rickets. So what you see here is me in the 60s examining a child with rickets in a clinic. And you shouldn't get rickets in Ethiopia because there's so much sunshine. It's actually, they jokingly say it's a country with 13 months a year of sunshine. So why would you get rickets? Well, you got rickets because people, covered up their babies all the time because they were afraid of the evil eye, especially of men. So they covered up the babies, and they got them uncovered, during the lectures about preventing rickets. But as soon as they left the milk lines, the kids were covered up again. So I began to see lots and lots of rickets. Now here's a classical example of the bowing that you see in rickets. And this is something you'll probably never see. It's carpal spasm caused by hypocalcemia. And this child shows the classical rachitic rosary, and collapsed chest along with it. So these kids have heart failure as well. And this was the child. This is kind of the beginning of my research career right here. This child has rickets, and I could show you the X-rays, but he has fractures everywhere. And he did not respond well to vitamin D. And I determined that he actually had, of all things, vitamin D-resistant rickets. And I put together a soup of phosphates of various sorts, and by the gallon, and his mother would feed him. And within several months, he looked like this. So I published my first research paper in the Ethiopian Medical Journal. And recently, I went back. I actually published 2 papers. And I went back and looked at those 2 papers. And without going through the details, one of them is really stands the test of time. The other is utter nonsense. It's just absolute nonsense. I can't imagine how it ever got published. It's just full of one mistake and anyhow, it's there you go. So I did my internship in pediatrics. At Stanford, I never saw a family doctor, and you couldn't be one if you'd never seen one. You know, we have this joke in family practice about education. The three principles of family practice education: the first is role models, the second is role models, the third is... There are no other principles than that. But, so I had become a pediatrician. The good guys, I thought, were pediatricians, and family doctors were not even in sight. And so in the Bronx, it was the third world conditions, lots of lead poisoning, kids eating paint chips. And in the middle of my internship, I got drafted. And to make a long story short, I met Bonnie, who is here, and I was in the military as a military doctor and heading for Vietnam, and decided to go to jail instead. And to make a long story short, I had to decide between jail and marriage. And figured out that marriage was better than jail, but for that we had to come to Canada. So we got married very quickly when we came to Canada, arrived in Montreal in the middle of the night. That's a whole other story, which I don't have time to tell you. I have to have a few beers about, you know, getting landed immigrant status in 20 minutes, which is what I did. Got to go back here for a minute. Sorry, I'm not able to return backwards. Can I? There's something back here. Yeah, okay. All right, okay, very good. So, as a house officer in Montreal, newly arrived, this kid comes into the emergency room, and he has a ruptured stomach, and he's clearly been battered, and then I noticed that he was a premature infant, and so the question crossed my mind, I wonder if there's an association between being a premature infant and being battered. So I looked in the records of the Montreal Children's Hospital for over 9 years, and there were 51 cases, and 12 of the 51 cases were former premature infants. So with the rate of prematurity being 6 or 7%, and that being 24%, there obviously was some kind of a connection. But to tell you the truth, it's not just, as it turns out, to be a former premature infant, but it's any infant with a chronic, difficult disease is subject to battering. In this case, the baby was very sick, and the mother was a teenager, and the baby had multiple procedures, and, you know, here, take your baby home, and, and you're a 17-year, 18-year-old, completely unsuited to care for a baby that is neurologically compromised, and you set yourself up for battering, and it's totally unfair to present a mother with that. So this was my first publication on low birth weight and the battered child syndrome, which I did in my residency program in 1969. Now, next thing that occurred is I'm in the emergency room, and in comes this child who is comatose, and the child is 2 years old. And the child is comatose, and this blood smear shows this. And this is basophilic stippling. And basophilic stippling is one of the hallmarks of lead poisoning. And the child, of course, I had been exposed to lead poisoning in the Bronx. And here I am in Montreal. There is no lead poisoning in Montreal. There aren't people eating lead paint, and lead paint is not a problem in Montreal. I'm trying to convince people that it's lead poisoning. They think I'm out of my mind. So the question is, if it's lead poisoning, what's going on? And the sad story is that a woman from the suburbs comes in, mother of this child, and she brings this pot. And in the inside of this pot, which she made, you can actually see the oxide lining the inside of the pot. And when we put apple juice in the pot, which is what she was feeding the children, it released just a catastrophic amount of lead. What had happened was the child had a bellyache, and the pediatrician recommended clear fluids, and she gave clear fluids from this pot, and the baby had bellyache, and he recommended more clear fluids, and the child basically died. He was so far gone we couldn't save the child, but the 4-year-old brother who had the same symptomatology and wasn't quite as sick, we managed to chelate and get rid of the lead. But then the question was, well, what was really going on? And I didn't know. I don't know anything about pottery. So what I did is I hooked up with a potter. And the potter knew all about it. And she taught me about pottery and lead glazes. And what she did is she produced hundreds of little identical cups that we put in various solutions in. And we also looked to see what was being imported, and we tested what was being imported, and 25% of what was being imported released unacceptable quantities of lead. And then I did a project with some medical students. I gave about 10 medical students $50 each at Christmas time, and I told them to go shopping. And I gave them no other information than that. Go shopping and buy what you like. And they came back with this. And then I tested that, and 25% of this pottery released unacceptable amounts of lead. I don't want to give you a talk on lead poisoning right now or pottery, but I can tell you that earthenware has the potential to leach lead. Stoneware does not. Stoneware, you don't usually use lead, and if you do, you fire it at 2,500 degrees, and the lead goes up the chimney instead of, it doesn't stay in the glaze. Earthenware pottery, the kind of stuff that you really see coming from Mexico in those lovely little slightly glazed brown pots, don't drink from those things. They are all, without exception, a setup for lead poisoning. But the question was a public health question. So here's the public health officer of Montreal, and we talked about that, and then we contacted the appropriate agencies on both the United States and Canada, and we managed to get a proper legislation in place to prevent this problem from occurring. Now, the sad story with this, well, there's many things that are sad about that, but the mother who made that pot made the pot according to the actual formula in a hobbyist lead book. And she did it correctly as the book said it should be. But to make a long story short, the formula was wrong in the book. That you need, to keep the lead in the glaze, you need double the quantity of silicon dioxide to lead oxide to be able to tie up the lead. And they had equal molar amounts, and that's why the lead released. So this was published in the New England Journal of Medicine as one of the lead articles. It's the first and last time I ever got anything published in the New England Journal. And you'll hear some more about that. But it was when I was a resident at the Children's Hospital also. I think I was a third-year resident. So we moved to Rochester following that, and did some research in Rochester. My slide's a little bit out of order, but eventually I was recruited back to the head of family practice at the Jewish General Hospital, which is a McGill family medicine program, and began a series of research projects, which I'll tell you about. But during that time, my mentor was Marshall Klaus. Does anybody know who he is? Yeah. Marshall Klaus is the sort of father of bonding. All the early studies on what happens in the early bonding period are attributable to him and his collaborator, John Kennel. And he helped me set up my first randomized controlled trial of a birth room in Montreal. And we were convinced that the new birth room, compared with the conventional setting, would have some important effects. And this is a sort of conventional setting. It looks like a hardware store. And this is the birth room kind of setting, very different. And we expected that there might be differences of an important amount, like cesarean section rate differences. There weren't. there was a reduction in episiotomy rate, and there were some other interesting effects which I won't go into right now. But what we did find is that some of the results were wonderfully paradoxical. If the woman was randomized to the birth room as opposed to the conventional setting, the good setting, the father would sort of go to sleep and read the newspaper and wouldn't be very interactive at all. And if she was randomized to the conventional setting, he was very protective of her. He was on top of it all the time. And not only that, but he was much more connected with his newborn baby. And that effect of connecting with the newborn baby lasted for a year. There was more kissing, more hugging, more attention, more time, more diaper changing. The father's role persisted over a year period. And again, there's lots to talk about there, but it was one of those funny results that you wish you didn't have, and you have to figure out what it all means. But it was an interesting result. I took a sabbatical in Oxford, and this is Oxford, and it was one of these life-changing events again. And this is Oxfordshire, and this is the center of Oxford, and these are a bunch of practices on the outside. And to make a long story short, what I did, there's a natural experiment going on here. That here you have a group of practices where the midwife and the family doctors work together collaboratively, and they do everything. They do the prenatal care and they do the birth. And then, because another group of family doctors have decided not to do interpartum care, you wind up with a complex system where the GP and the midwife in the community do some prenatal care. Some more prenatal care is done by other midwives in the hospital. The birth is done by somebody else, and the postpartum care is done by somebody else. So you have a very complicated system that's laid on simply because that GP doesn't do interpartum care. And the results of that were quite dramatic. And the question was, is this complex system going to cause problems or not compared to the simple system? And it was really a high-tech versus low-tech, high-tech, low-touch care versus low-tech, high-touch care. And the results of the system I'll show here, but I'm going to summarize them in this slide, which basically says that if you put normal women side by side with women who are high risk, you make them sick. If you treat high-risk people in a high-risk setting, you make them well. It's appropriate for that. But the results of this study were widely published in the British Journal of Obstetrics and Gynecology and in several other British publications. And Bonnie and I got to meet some interesting people, and we got to present that. Some of you will recognize who I'm talking to. She was the patron, this is the Queen Mother, and she was the patron of midwifery in the UK. And this is in the Nuffield Gardens in London, which you'll know about. So I was a Nuffield Fellow. Back to McGill, post-sabbatical, I was thinking about episiotomy. And this is an interesting picture in retrospect, because she's the mother of a young woman who's now 25, whose birth I attended, who is now a medical student, third year at McGill, who has written a paper. She's the first author of a paper looking at the beliefs and attitudes toward birth of junior college students, and that showing basically that it's too late. That if you want to teach people about birth, high school and junior college is too late. You actually have to start way before that. But what was really interesting in that study is that the students knew all about breastfeeding. They knew the benefits of breastfeeding. They had received the public health messages about breast is best. And as much as they knew about breastfeeding, they knew absolutely nothing about birth, and what they knew was wrong. Now, in setting up this study about episiotomy, I wanted it to be scientific. So I wanted to write on paper and make interesting, I wanted to be a scientist, right? So So what you see here is electromyographic perineometry, Kegelometry. Okay? So the women are asked to do a Kegel, basically, and these are short Kegels, and then these are holds that last for 10 seconds. This woman has a strong pelvic floor, and there's a little decay, but not much. You'd expect that with the series. And we studied that as one of the things that were part of the episiotomy study. And through all of this, I had mentors. Mary Ankin, who is the author of, one of the 3 authors of The Effective Care in Pregnancy and Childbirth, was one of my mentors, and so was Alec Turnbull, who was head of obstetrics at the Nuffield Department in Oxford. So the question is this: does median episiotomy prevent perineal trauma and pelvic floor relaxation? But the larger question, or maybe the question for this audience, is what the hell is my obsession with episiotomy anyhow? Right? So here's the story. I'm in Ethiopia, and I'm in a children's hospital, and when things got quiet at night, I go across the little tunnel to the general hospital, and the midwives would let me catch babies. So I'm delivering 200 babies before I do my third-year clerkship back at Stanford. And on the first day of my obstetrical clerkship at Stanford, I delivered my second patient, and there's a heavy hand on my shoulder. And it's the professor and chair of the Department of Obstetrics and Gynecology at Stanford. And he says, "Mr. Klein, come into my office. We need to talk." It's pretty scary. So I scrub out and I go into his office, and he says to me, "Mr. Klein, if you want to practice primitive medicine, you'll have to go to the county hospital." Now, do any of you know what that means? In the U.S., the county hospital is poor person's medicine. You can do anything. But in the university hospital, you're not going to practice primitive medicine. So what was my crime? No episiotomy. And then he said to me, and maybe it was a joke, and maybe it wasn't, on my service, every woman will have an episiotomy. And if she doesn't get one before the birth, she'll get one after. So to make a long story short again, I go to the county hospital, present myself to the chief resident, who was an alcoholic, and he says, "What do you want to do?" I said, "Well, what students do." He said, "Anything else you want to do?" "Well, how about I look after the babies after I deliver them?" "Well, go talk to the head of pediatrics." Because it's all compartmentalized. We're talking about 1964. No, 5. And so I go to see the head of pediatrics, who's a very sweet man. He says, "Great, why don't you do that?" So, of course, in retrospect, it's the beginning of family medicine, right? But I don't know that because I don't have a label for it. I've never seen a family doctor. I don't know that that's what I'm doing. I'm just doing what's fun. So anyhow, I tried to get funded for the randomized controlled trial of episiotomy, and I get the results back, and they are overwhelmingly negative. Now, in the meantime, Bonnie, 25 years ago, has a stroke and is quadriplegic and on a respirator, and I'm in London, Ontario, where we found a surgeon who's been operating on dogs and waiting for a patient, because it's a brainstem stroke, and that's another whole story, and was inoperable in Montreal. So we're there, and I have other things on my mind than a randomized controlled trial of episiotomy. And I get a phone call, and the phone call is from Health Canada, who I've applied to get this study funded. And there's a woman I've never heard of on the end of the phone, and she says, "How come you haven't responded to the reviewers?" I said, "Well, look, my wife has just had a stroke. Forget it." And besides, I'm never going to convince these reviewers of anything. They're out of their minds. She says, "Do it." I said, "Are you listening to me? I'm busy." She says, "Do it." So what is she trying to tell me? She's trying to tell me that they want to fund the trial. And they don't give a damn what the reviewers are saying, right? And she says, basically, answer the reviewers. So it was very therapeutic. I just let it all hang out. And so here's reviewer number 5. You can read it for yourself. So here's what I say to reviewer number 5. It will be very hard to convince 5 that this study is worth doing. We will draw attention to an editorial in the British Journal of Obstetrics and Gynecology basically calling for just exactly this kind of study. And that was one example. And we went ahead to, again, provide information which you now can read for yourself about how I responded to them. Basically, I was not kind, and it was very therapeutic. So this is the story of how I got connected with episiotomy. Now, very important in all of this is Janusz Kazarowski, who all of you know. Now, Janusz had just finished he was just finishing his PhD at McGill. And I can hardly remember now how I got hooked up with Janusz, but I needed somebody like Janusz to work with me on the episiotomy study when it was funded. And I discovered Janusz somehow, and we began a relationship that has continued to the present time, and is still going on, by the way. Now that he's moved back to Montreal, he is still collaborating on studies that we are doing still and are still applying for things together. Point being, obviously, I've really had very little formal training myself, and the kind of training that we offer in the Clinical Scholars Program or that Martin wants to develop in a master's in family medicine, I had none of that. I had a 1-year fellowship in community medicine at Rochester. And as part of that, I studied the Neighborhood Health Center network. I looked at a control group in the community that was not exposed to the Neighborhood Health Center, and we were able to show a dramatic reduction in emergency room visits and in hospital admissions for children in a study that I had good mentorship for. So it set me up for doing this kind of research. Just a few bits and pieces from the episiotomy trial itself. We're looking at perinatal trauma and pain on day 1, 2, and 10 put together. And, the people who are intact have the least amount of pain. The people who have episiotomy, spontaneous tears, a little more pain. The people who have an episiotomy, still more pain. And the people whose episiotomy tears to a third and fourth, of course, have the highest amount of pain. But the most important thing is here. It's showing clearly that spontaneous tears are less painful than episiotomy, which episiotomy is a deliberate second-degree tear. And here you see, 3 months postpartum, the women who are intact are still having less pain. There's equivalency between spontaneous tears and episiotomy. And of course, those who were unfortunate enough to have a third or fourth degree tear of the worst pain is going out to 3 months. But look at this, 52 out of 53 of the women who had a third and fourth degree tear had it in the presence of episiotomy. There's only one woman in the entire trial who had a spontaneous third and fourth degree tear. So this was part of the story that Michel, rather than Jerry, was singing about in his poem last night. When, the odds ratio is 20. You're 20 times more likely to have a third and fourth degree tear with an episiotomy. But then Janusz and I got interested in physician behavior. And we went inside the trial itself to see what we could learn inside the trial about the attitudes and beliefs of the physicians who participated. So what we did is we divided the physicians into, very crudely, these are the terms I actually use, low cutters, mid cutters, and high cutters. And I presented this at the North American Primary Care Research Group meeting. And the reviewers, who are us, right? They're family doctors, shredded it, one of them. And I was hoping to get an extended paper I was able to do a 15-minute presentation, but the extended paper did not happen because of this reviewer who said that I was biased because of the terminology that I used. Of course, I don't know who that reviewer is. But what we learned is that the high cutters, of course, have no intacts. These 3% must have got there before the doctor. And then the third and fourth retear rate is more than 20% among the high cutter group. And actually, we even learned in an N of 1 case that that the people who were the high cutters really thought differently about the whole process. That the high cutters in this study also randomized less often, and among the non-randomized did cesarean sections at a very high rate. They diagnosed fetal distress at a much higher rate than the low cutters. They saw the world through a lens that saw childbirth as scary indeed, and that baby needed to be expedited out of that unpleasant place. You know, women are unexploded bombs that need to be defused. And that's the kind of attitude that the high cutters had. But then I had to get published. I sent it out to the New England Journal, and this is what they said. And they never even sent it out for review. Okay? This was a rapid turnaround. And then it was rejected at JAMA. There were 4 reviewers. The first was positive, the second was negative, the third was positive, and the fourth was overwhelmingly negative. He questioned this study as a legitimate area of study. He said that it was not worth studying. And then he said that you think this is the first North American trial. It's not the first North American trial. Here's the first North American trial. And he quoted this fellow named Gainey. And what Gainey did is he looked, it's quite unbelievable, he looked at a cohort of people that he looked after in the 1920s, and he compared them against another cohort of women looked after by residents in the 1940s. And that reviewer said that that was the first randomized controlled trial. I couldn't take it. I called up the editor of JAMA, and I gave him a piece of my mind and about his review process. And he said, I'm sorry, Dr. Klein, the fourth reviewer is our principal obstetrical consultant. It was eventually published in the online journal of current clinical trials. Mary Ankin helped me to get that published. The journal didn't last very long. It was the first online journal. And they published it as their lead article, and they launched their journal with it. I guess maybe it's because why the journal didn't last. I don't know. So there were a series of other papers, and the New England Journal and JAMA turned them around in record time. And again, the review process of the journals, were such that the attitudes of the reviewers were just misogynistic and loony, and I really couldn't take it. And so and this is the message I'm giving you, I called up the editor of the American Journal of Obstetrics and Gynecology, and I read him over the phone what his reviewers had said. And he was embarrassed. And the point is that the journal's editors really do want to publish a good journal, and they want controversial stuff, and if their reviewers are acting crazy, they'd like to know about it. So he said, you're absolutely right, this is unacceptable, and he sent it out for review again, and it came back positive. I don't know who he sent it out to. And he published a series of 3 articles on pelvic floor functioning, on episiotomy, on the behavioral stuff. So the point here is very simple. If you are doing research that contests the current orthodoxy, don't expect to be loved. I mean, it's just not going to happen. And when you get your rejection, you don't take it personally. It's all part of the game, really. And in these, I wrote an article, which some of you might like to see sometime, about this process, in which I actually used the words of the reviewers as the substrate for the article. And you don't take it personally. It's just the way it is. When you're involved in paradigm shift and you're in paradigm A and everybody else is in paradigm B, that's the way it goes. So I'm recruited back as head of family practice to BC Women's, and there I tried to develop research. I was head there from 10 years, from 93 to 2003, and it was a very unique opportunity. It's the largest maternity care facility in Canada. And one of the first things I did was to look inside the department itself to try to figure out variation within the department. So here's episiotomy again. But what I did here is every year I gave every member of the department anonymously and confidentially their own results, their own episiotomy rate, forceps rate, vacuum rate, induction rate, epidural rate. And they would get a report like this. They would actually get a graph like this that would say, here are 15 people with a 0 episiotomy rate, and here are 9 people with a 100% episiotomy rate, and here's you with a 45% rate. There'd be an X right here. And the departmental rate is 47%. Okay? So I did that for every group. So what happened here, in very short order, the episiotomy rates go way, way down from 60% to 13%. The third and fourth tear rate goes from 12% to 7%. And here we find that there's only one person left in the department 5 years later with an episiotomy rate of 100%. The others have either retired or changed their behavior. We don't know because it's confidential. You just don't know. Now, we do all of this for all the other rates. Now, to take the bigger picture here, this is what happened in the United States post this study, and this is what happened in Canada to episiotomy rates. And the third and fourth degree tear rate goes from 4.2% to 1.9%. So that is what happens when you restrict episiotomy use instead of doing it routinely. Now, obviously, this is the most important thing I've done. Everything else has been, in many respects, variations on the theme of behavior and changing behavior. So now we look at epidural rates in a similar way, and we see that here's 13 people with an epidural rate of 0 and 17 people with 100%, and everybody else distributes in a rather normal curve. And the average rate for the department is 57.4. And I wondered whether the people who had high versus low rates had differences in other aspects of their practice. And what you see here is that for nulliparous women, the low episiotomy users, rates 0 to 40%, have a cesarean section rate of 14%, while the high people have a cesarean section rate of 23.4%. But for multips, there's no difference. It's hard to screw up multips. It really is. But primips you can screw up. You really can. And we do on a regular basis. And so there's a question here. So we then did a whole series of studies that I don't have time to tell you about. But I can tell you that the low episiotomy users don't simply do fewer episiotomies. They do fewer of all kinds of things. They spend more time with their patients, even though their patients spend less time in hospital. Say that again? The patients come in later, but in absolute terms, they spend more time. How did we know that? We had medical students with clipboards wandering around the delivery room with stopwatches measuring these things. Okay. So then we look to see other outcomes. And here we see, I won't go all through them, but obviously the high epidural users have the lowest spontaneous delivery rates and the highest cesarean section rates. You just saw that. But look at this. The 5-minute APGAR scores of the low 5-minute APGAR scores are double among the high epidural users. And it's meaningful. It's not just a number. Here we have the difference in newborn intensive care unit admissions being double also. So there's a real outcome here. And we published this with Stefan Jabowski was one of my collaborators on this one. And we published this, Okay. So, again, I kind of got obsessed with epidural in the same way previously I got obsessed with episiotomy because it seemed to me that epidurals had a really profound influence on the system that people were really denying. I also looked at the data that was out there and the randomized controlled trials that were informing people's views about epidurals. And I began to think about meta-analyses and the use of meta-analyses and the misuse of meta-analyses. And what you really have to do is look at both the left and the right side of the equation. You have to look with your right brain and not just your left brain. You have to look to see not only what is happening now, but what the long-term consequences are of what you do. And most of the data that's out there is about an event, not a woman's entire reproductive trajectory, which is what you really have to look at. So, you know, if 3 out of 4 Canadian women receive an epidural, it's clearly transformed childbirth. And why aren't we talking about it? Why don't we asking the question? And the answer is pretty clear, and that is that it's so common now that our trainees are being trained in an epidural soup, and they don't have any comparison base. Okay, so I began to look at the studies, and the Cochrane, the original Cochrane showed that there was a 10% increase in cesarean section rate, but the next Cochrane said there was equivalency. That epidurals did not increase the cesarean section rate, and that's what the present Cochrane still says. Now, the Cochrane is based on randomized controlled trials, level 1 evidence, you know, good stuff. So what we look at is the oxytocin use, and we see that it's much higher in those who get an epidural. We see that the malposition is much higher. We see that forceps and vacuum are much higher, and perineal trauma as well. You see that fever occurs much more often in epidurals. But why doesn't it increase the cesarean section rate? I have to ask the question, because the belief system is that it doesn't. So here is what I did. I looked inside all of these studies, and I did ultimately a sensitivity analysis of each of the studies. This is very bad news, because what I'm telling you is you can't use the meta-analysis, which you thought was going to help you, so you didn't have to look at so many studies. I'm afraid not. You have to read them all, because some of the studies don't belong there. So if your baseline rate of episiotomy is 12 to 13%, instead of what? 90%, 80%? You don't have much place to go to improve. And look at their rates, 12, 10 to 14. Here, Sharma, 5% in both arms. They don't show a difference? Big surprise? Not only that, but they randomize their patients at 4 or 5 centimeters when the women are already in the active phase of labor. When do we give epidurals? At 2 centimeters, at 1 centimeter, in the parking lot. I mean, so the data does not apply to the way we use the technology. And Sharma's data, which has the largest number of cases, overwhelms the whole system. And it's the reason that you get a false result from the meta-analysis. So what I did is I threw out all the studies that randomized before 4 or 5 centimeters and left the ones that randomized early. And what you see here is that the cesarean section rate odds ratio is 2.59. So you're more than twice as likely to have an epidural. Now, why wasn't this published by Cochrane? It should have been. The data was all there. They did a number of sensitivity analyses, but not this one. Now, all I can tell you, I mean, you can believe in the devil theory of history if you like, or the incompetence theory of history, or a combination of both. But I can tell you that the Cochrane's work on epidural has been completely run by the anesthesia community since day one and continues to the present time. And they will tell you that epidurals do not increase the cesarean section rate, and they will tell you that epidurals given early do not increase the cesarean section rate. And I don't have time to go through that study. Now, the late Phil Hall, a colleague of ours, came up with this wonderful statement. Okay? Basically, what we have done, he says, is we have gone from evidence-based decision-making to decision-based evidence-making. That means that you design your randomized controlled trials or your meta-analysis so that they show the result that you'd like to see. And you stick in the studies that you like, and you throw out the studies that you don't, and you wind up with totally useless meta-analyses. Garbage in, garbage out, and the literature is full of it. And you have to be very suspicious. You have to ask whose evidence, whose randomized controlled trial, does the study apply to me? Is it really true? Is it true in my life? Does it have external validity or just the internal validity of that particular study? Okay. One of the other things that happened is that the SOGC produced a guideline that said that if you did less than 25 deliveries per year, you should quit or retrain on a regular basis. And then the Saskatchewan College of Physicians and Surgeons adopted that as a regulation. Saskatchewan went from 80% of their births by family doctors to 20% in 5 years. They quit. They said, I'm not going to retrain every 2 years. So what I did is I asked the question, what is this volume story anyhow? And so we looked, and I'm going to just gloss over this very quickly. We looked at very low people with 10 less than 10 a year, less than 25 a year, more than 25 per year. And we looked at their induction rate, monitoring rates, blah, 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 section rates, episiotomy rates. We looked at their newborn outcomes. There's no difference by volume. But there is a difference. Would any of you like to guess what the difference is? What characterizes low-volume physicians from high-volume physicians? Any hypothesis? They get more sleep. Yes? They spend more time with their patients. Low volume? It might be true, but I couldn't measure that in this retrospective study. It's an interesting idea. Anybody else? Okay, the answer is that they consult more often. Okay? So here's the consultation rates. The low people consult up here, and the other people down here. Pediatric consultants the same. And in so doing, they get the same result as the other people, right? So why shouldn't they consult more often? It's not a problem. They just do. Okay. But, and I get a kick out of this piece, what about us older physicians? Aren't we better? Aren't we? Does experience count for nothing? What do you think? You think experience matters? Actually, it matters. It actually matters. They actually do marginally better. But that's not a problem, because you can always get older. But you know what? It's not significant. It's a fact, but it's a useless fact. So take it away as a useless fact. There's really no difference. This is our son Seth and our daughter Naomi. I don't know why I put it in here. It's just one of my favorite pictures. Okay, our current research is about attitudes and beliefs of all of these people in childbirth. And if I run out of time, that's okay, because Ashay is presenting our current data, which come out of this. But as much time as I have, I'll show you where we've gone. In the first study, we basically learned that obstetricians and family practice residents are from Mars, midwives are from Venus, and family doctors are sometimes Martians and they're sometimes Venetians. And they're looking for a friendly planet, and sometimes they find it and sometimes they don't. And we have a lot of work to do. So, this person, this person, this person, this person, this person, this person, what do they have in common? They all had elective cesarean sections, and they all talked about it incessantly. And that's the beginning of our current era of cesarean section by choice. Now, this is from the Vancouver Magazine. Look at this. Oh, sorry. This is giving birth the modern way, the C word. Wouldn't you like to have a C? I mean, it really sounds good. I'd like one. Take a look at this quote. What is it? Well, Joseph B. DeLee said this in 1921, and he was talking about episiotomy. And he was going to solve this problem by routine episiotomy. I can tell you that the language around this justifying episiotomy has now changed. That's good news. But this kind of language is now used to justify elective cesarean section. And the current landscape is very much favorable toward a woman's right to have a procedure for which there is no indication, because autonomy trumps evidence. And even family practice people believe that to be true. Obstetricians believe it to be more true, but we believe it to be true as well. So Janusz and I looked strangely, this stuff never goes away. We still had the data from the Montreal episiotomy trial 20 years later, and asked ourselves, I wonder if we have some of the answer to this question in that old data. So we went back and we looked in the old data, and we collapsed the two arms of the study so that we wound up with more than 1,000 women. We had a 95% follow-up rate. So the women who were in the study wanted to stay in the study. And so we followed them out to 3 months. And we looked at more than 1,000 women, and we asked a whole series of questions that are listed here. And we studied a whole bunch of stuff, and I'll show you a little of the results. So here we see if you're having loss of urine 3 months after you have your baby, and these are people who had intact perineums or first or secondary tears. These are those who had episiotomy or extension, and these who have cesarean section. You see, by having a cesarean section, you can't eliminate urinary incontinence. It is slightly less so at 3 months. Now, the most important question, I think, is a quality of life question. So if you ask the women who have urinary symptoms of any kind, is it severe enough for you to wear a pad, which is a quality of life question, you see no difference. And that's only 3 months. And I can tell you that by 6 months, in other people's study, the differences just wash out. And by age 50, urinary incontinence is no different by any mode of birth. And the incontinence rate of nuns is 40%. I'd give you other data of that sort. It just tells you that you can't avoid urinary incontinence by having vaginal birth or a cesarean section. But our obstetrical colleagues believe that you can. Now, part of this study, we asked lots of questions. Here's one of them, sexual dissatisfaction, and you see no difference by mode of birth. But look at the bottom one. One of these questions, one of these things that you find that you wish you didn't know. I don't want to discuss this any further. That's just a thing. But I can tell you that the pain and frequency of intercourse is the same in all the groups. And I can tell you that the people who have the least pain are those who had intact perineums. Of course, you can't have an intact perineum if you have an episiotomy. And here you're comparing intact perineums against cesarean section, and you see that the pain on intercourse is less with intact perineum, even though these people didn't have a baby through the perineum. The section people still had more pain. I'm going to skip over this for time, but to just say that Patty Jensen and I, Patty's the PI, did a study on home birth in British Columbia. And to make a long story short, this is the important outcome, and that is there is no difference for babies born at home by intention to treat, the same midwives delivering them in hospital, or a matched sample of physicians delivering in comparable hospital settings. There is no difference. And the very good news about this is that on the basis of this data, the College of Physicians and Surgeons of British Columbia rescinded their prohibition of having family doctors or any other physician be involved in home birth. And they did it on the basis of this data, but they also did it on the basis of the ethical aspects of that. And that issue of the ethics of women's choice was very important. It was done with Karen Bueller and an obstetrical colleague who worked collectively to talk with the College of Physicians and Surgeons and get this result. So we'll skip over that. But this is a caveat for home birth, and it's actually a caveat for hospital birth as well. That home birth or hospital birth is really neither safe nor unsafe. It really depends on many things. And if we have safe home birth in British Columbia, it doesn't mean home birth is safe somewhere else. It just means under these conditions, with midwives and physicians and hospitals having good relationships and being mutually supportive, there is no difference. But if you have a chaotic environment or a dysfunctional environment, you won't get the same result. Okay, so I'm going to just skip over a whole bunch of studies that I did on rural British Columbia and sustainability of communities, simply to tell you that at this very moment in Banff, using our data, they are trying to get rescinded the elimination of maternity care from Banff Hospital. Using our data, Banff is a sweet little hospital with about 100 births a year, and they want to close it. They have a section rate of 8%. Canmore has a section rate of 38%. They want the women of Banff to go to Canmore. They have tripled the third and fourth degree tear rate in Canmore versus Banff, and they want to replace maternity care with, are you ready for it, pay-as-you-go plastic surgery. Just what Banff as a community, destination plastic surgery, a money-making procedure for the hospital. And we've helped the community to march in the streets with pots and pans, and the Minister of Health will not speak to them because he says the issue has become politicized. You're damn right it's been politicized. And we're really pleased that this kind of stuff is useful. All the information that you know about on the attitudes of family doctors and midwives and obstetricians from the national study, I think you've heard me talk about before, so I'm not going to talk about that. I'm just going to talk about the family practice piece. And I'm not going to talk about it with data. I'm just going to talk about it. We looked at, within the national study, we looked at family doctors of three types. Family doctors who do antepartum care, family doctors who don't any longer, and those who never did and never will. Okay. And we find that the family doctors who don't practice obstetrics have attitudes that are more, if you'll pardon the expression, right-wing than the obstetricians. They are more negative about childbirth. They are less positive about the role of the woman in her own birth. They are more favorable to episiotomy. They are more favorable to epidurals than obstetricians even. Which, of course, is why they decided not to do maternity care, because they're terrified. We have taught them to fear childbirth in our residency programs. So what? They're not doing antepartum care. What's the problem? They can have whatever attitude they want. Well, unfortunately, there is a problem. The problem is that more than 50% of the antenatal care in this country is done by family doctors who don't do antepartum care. And by the time they send their patient off to usually an obstetrician, rarely another family physician, and certainly rarely a midwife, they have poisoned the well. They have helped to create attitudes in the women that they serve that won't be fixed. And they are contributing to the rise in the cesarean section rate and other issues. So we have a problem. That study was published in the Canadian Family Physician, and the College of Family Physicians had done absolutely nothing about it. There is no activity to try to make the changes in our curriculum necessary to fix this. We have to provide courses for family doctors who don't do interpartum care, so that they really know what's going on in the delivery room, so that they can provide accurate information to the women under their care. So that's our problem. We also know that younger obstetricians are terrified of childbirth and are themselves choosing elective cesareans. So you can imagine what they are telling their patients. So all of that is what's going on at present. The current research is about providing women with the kind of information that they need so that they can have an adult conversation with whoever is looking after them. What we know from our national study of 1,350 women across the country is that, depending on the issue, late in pregnancy, between 30 and 50% of women either don't know what they need to know or what they know is incorrect. And if you couple that with the 30% of providers who are operating in a non-evidence-based framework, you can imagine what kind of a conversation takes place between an I don't know with an I do know and what I know is wrong person. And informed consent under those conditions is a sham. So we have a huge problem that we have to try to fix. And rather than talk about that, I'll stop now, and when Ashaya comes later in the morning, she'll talk more about what we're doing right now to try to do something about that. So thank you very much. I don't know whether we have time for questions or not. We're tight, probably.
Thank you, Michael. I think, I know we're tight, but probably we should leave time for a few questions. And it's such an interesting talk. If we can always catch up. We have quite a long lunch, so we do have a little window we can catch up if there's any questions that people want to ask Michael.
I think I terrified you. Yes?
So, not knowing a lot about medical education, what kinds of educational programs would you think to target it?
So the question is, what kind of educational programs? The problem is not that obstetricians are surgeons. They are. The problem is that we as a society have turned normal childbirth over to surgeons. That's the problem. Obstetricians spend weeks with a urogynecologist so that they see childbirth through a urinary incontinence lens. They spend zero time with a midwife. Family doctors are taught largely by obstetricians. Obstetricians should be doing consultative work, and when they do, it's not a problem. But in Ontario and Quebec, most of what an obstetrician does is primary care. So I think we have to redesign the whole educational model. And the answer to the question is so complicated because there are no quick fixes. The system is fundamentally broken. Now, this is actually good news because it is so broken that it is at the point where it actually has to be fixed, because the average age of an obstetrician is 57. Family doctors are bailing at an absolutely incredible rate. When I took over in '93, there were 2,400 family doctors doing maternity care, and they did 80% of the births in BC. There are now 700 family doctors doing maternity care, and they do 60% of the births. Our residents have the best results in the country. Approximately 50% of our residents go into interpartum maternity care in their future practice. At the university in London, in Western Ontario, there have been 3 years running when not a single one of their graduates has incorporated maternity care into it. Okay? So the policymakers, the educators, have to decide what kind of maternity care system they want to have, and they have to design it so that the experiences that people have are the right ones and not the wrong ones. And I think a collaboration between midwifery and family practice is critical. We have only a single example in this country of a true collaboration between midwives and family doctors, and it happens to be at the South Community Health Center in Vancouver. And other models have to be developed, and they have to be used educationally to expose people to the possibility of collaboration. It's a whole talk in itself, but the point is that it probably will have to be fixed because it's going to collapse. And at that point, it can be designed properly. Anybody? Okay, all right.